Hello, hello. My name is Jean-Louis Vincent, and I am very pleased to moderate the very first ISICEM chat. And for this, we have a fantastic interview today as Anthony Gordon from London accepted to answer a few questions and tell us what's going on, not only in the UK, but elsewhere. So, Tony, thank you for being with us, my good friend. Maybe you can introduce yourself in a couple of words.
Yeah, thank you, Jean-Louis. It's a pleasure to talk to you. Yes, my name's Anthony Gordon. I'm Professor of Critical Care Medicine at Imperial College London and an NIHR research professor. That's my position.
Very good. Yes, indeed. You are both a excellent clinician and a outstanding researcher, trialist, and we will, of course, cover the two. Maybe the first question comes obviously about the situation in London and perhaps in the UK. How are the things now?
Yeah, things are still very busy and maybe even increasing. This second wave has affected much of the country. We thought it was starting to ease again, but evidence of this new variant may be spreading more quickly has seen a rapid increase in cases. So certainly our ICUs are getting full again, as is the hospital. Thankfully, not as bad as the first surge in April. Things are more controlled, but still everybody's working flat out, I would say.
But you still have some beds available. It's not the 100% occupancy rate.
Back in April, we were at times 200%.
I know, but now, yeah.
But now, for COVID, no, we're personally somewhere 30 to 50%, but we're still now got other patients, and that's the difficulty. There isn't a lot of room, so maybe again surgeries will have to be cancelled again if we keep on getting this rise in COVID cases.
Can you tell us a little bit about your current management of severely ill patients and perhaps what you do differently from others? Who knows?
I don't know if we do things differently to others. I think we've learnt a lot over the last 9 months, and our care is different to what we were perhaps doing in March and April. So I think obviously
respiratory-wise, you think?
Yeah, I think there was a lot of uncertainty, very polarized opinions around whether patients should be intubated early or whether they should be intubated late. And I think perhaps we've come more to a middle ground, and that says don't rush to intubate. If there's no need to intubate someone, why would you do that? And do your normal respiratory management. But if the patient is getting worse or not improving, then don't be frightened to intubate and do that. So I think, I think that's one of those important things, some extremes of treatment, which people proposed when there's a lot of uncertainty, that now we're coming back to, I think is important, very sensible, good intensive care management. And these things are helping.
Perhaps a little more personalized in terms of intubation. Can you individualize these decisions more than at the beginning?
I think it's going back to using that clinical acumen rather than having a blanket rule that we are always going to do this or we're always going to do that. It's coming back to experience and knowing this patient does need intubation because something is deteriorating. Either their oxygenation is getting so much worse, or they look like they're tiring, something like that, rather than having a fixed rule that we must follow. I think that's also easier because with numbers more under control, you've got full-time intensive care specialists looking after the patients, whereas in April, many of us were stretched and we had great help from colleagues who were less experienced. They did the best they could, but they were looking for clear guidance. And I think that's why, as a specialty, we show how we improve patient care so that we can make these informed decisions for individual patients.
Do you have, in part, the same people coming back, but maybe they are a bit more trained, a bit better trained, and a bit more experienced than last April?
We're not so far, because things are a bit more under control, we're not having to rely on people coming in. But I think also, yes, there's now those people who perhaps always have an interest in critical care are volunteering to come and do that. So yes, I think there's a part of that.
Okay, except for the respiratory management, any difference? Of course, dexamethasone comes to mind, but there are perhaps other things to mention.
So I think dexamethasone is the biggest treatment that we feel most confident around. I think the evidence from first the recovery trial, but then the REMAP-CAP trial and all the other trials that came together, published in JAMA in September, and a meta-analysis that came out at the same time showing quite clearly steroids improved outcomes for these sicker patients. So I think tackling that inflammatory response is important. That's one treatment. I think on the ward, I think there's still uncertainty around the antivirals, particularly remdesivir. It's used a lot. Maybe in the less sick patients, it has a role. I think by the time patients come to ICU, I don't think it has much role there, or the evidence is quite clear. At that late stage of disease, it doesn't help. Yeah, and I think again, just think people have learnt with experiences at the beginning when everyone was concerned about oxygenation. Maybe patients were kept a little bit dry, trying to improve oxygenation, but then the concern over acute kidney injury, people have gone back and said, all right, we must make sure the patients are adequately hydrated, euvolemic, rather than maybe people were aiming for too much dehydration to try and improve oxygenation. And I think that has changed over time.
Yeah, at the beginning, maybe people focused too much on the pulmonary edema and were indeed using diuretics quite liberally with some fluid restriction. And maybe, they kept the patient somewhat hypovolemic, don't you think?
I think that's possible. Yeah, I mean, it may also be the use of steroids is reducing the inflammation and reducing the kidney injury potentially as well, I think. So, but I just noticed this difference in the patients, which is encouraging. It felt at times in March that this was almost an untreatable disease. It's still a very nasty disease. Don't get me wrong, I think, but it doesn't feel hopeless anymore. It feels it's becoming more like a serious critical illness that we can manage but need to take seriously.
Anticoagulation, a bit more liberal than some months ago?
Potentially, yes. So certainly it's been used, but people will be aware of a recent announcement coming from the REMAP-CAP trial, combined with international collaboration with the Active-4 trial in the US and the ATTACK trial led out of Canada, that we've been randomizing patients to prophylactic dose of heparin versus a therapeutic dose of heparin to try and prevent clots and obviously improve outcomes. But we've just been told by our data and safety monitoring board actually to stop randomizing in the severely ill patients in the ICU for futility. It wasn't improving outcomes. There's potentially a signal for harm, and obviously we're not surprised that patients getting therapeutic anticoagulation had more bleeding. So we've stopped randomizing patients in the ICU. They've advised us we should continue on the ward. So maybe there's a different effect on the ward, and I think there's still uncertainty about that. But in ICU now, I think we're being more cautious with the anticoagulation, and I think maybe it's the anti-inflammatory treatments that may be most beneficial for these sick patients in ICU.
Before we go into that, is the problem with heparin primarily the bleeding, or is it that it's useless because indeed the process is already in place and you can no longer revert it quickly with heparin? What could be the reason?
I think the answer is we don't know at this stage. This has come out in the last few days, and things are moving so fast. And of course, we will try and answer those questions. I think it could be any of those. I think it's an immunothrombosis, and we know that often doesn't respond well to heparin. But it may be that by the time you come to ICU, it's a bit late. Maybe there are microthrombi before, or maybe they're just a higher risk for bleeding. I don't know. And this will come out over time. But I think this shows the importance of why we do RCTs. Because I remember people saying to us at the beginning, how can you randomize to anticoagulation? You can see the clots forming, you must give it.
Yeah.
It's maybe we'll look at this as be surprised, but this is the importance. And now, again, we can still improve our care through research.
Yeah, it's so important to have RCTs for this type of specific disease. People used to say the same thing about hydroxychloroquine. Why don't you give it? It's not very toxic. It may help, who knows? And now we know that we should not use it. Tocilizumab, you are in a good position to tell us what you think.
Yeah. So I can tell you, again, from our interim analysis in REMAP-CAP trial, the DSMB, when they carried out the interim analysis, told us there was a signal for efficacy, that it had passed the statistical triggers, that it was improving outcomes compared to the control group, which was no immune modulation. Now, their advice to us was, because we are this platform trial that's testing multiple interventions, we have other immune modulating drugs within this domain of the trial. And they said, at this stage, we only know that tocilizumab is better than control in that interim, but there are other immune modulators. We've got sarilumab, another IL-6 inhibitor, and anakinra, an IL-1 receptor antagonist. They said maybe these work as well or even better. So they suggested we should stop randomizing to the control arm and compare now these different agents. So that is still going on. We also were in the maybe strange situation that because of the pandemic, recruitment has been so high. We've been recruiting just in the UK last week, 200 patients came into the trial last week alone.
Wow.
So by the time the DSMB analyze, there are many hundreds of patients already included. So what we said was, as there are many patients already randomized, we want to give the best result, the most detail. So we let those patients follow their follow-up, 3 weeks follow-up. The database has now been locked. The statisticians are analyzing the data, and we hope to have the full results to present in the next week or two. I can't give an exact date, but we will try to get out a full detailed analysis and publication as quickly as possible. But it was quite a big signal seen in the interim, an odds ratio of 1.8. A high odds ratio greater than 1 suggests a good outcome. So that's a big effect. What we saw in steroids was because about 1.4.
We could, yeah, absolutely. Yes, indeed. That's what you mentioned in your press conference as well. So people read the recent report in the New England Journal of Medicine with negative results. I mean, no difference in outcome, tocilizumab versus placebo. So how do you explain these discrepancies? Is it a matter of patient selection?
Yeah, I think the last trial that came out last week, the IMPACTA trial, I mean, it hit its primary outcome, which was a composite endpoint of the need for ventilation and mortality. But as you rightly say, the signal was all in the prevention of needing ventilation, and there was no signal really for improved mortality. So I took this to mean the drug is looking useful. It may have a role. It may be that in order to see the most benefit, that you've got to give it to the right patients, and it probably is the sicker patients. And I think that is the difference between REMAP-CAP and many of the other trials looking at tocilizumab or other IL-6 inhibitors. They've often recruited patients on the ward, less sick. And some of those that have included patients on the ICU have also included patients late in their ICU stay. There's been no time limit. We had a strict time window that you had to be in the ICU requiring some degree of respiratory support or other organ support, but that could be high flow nasal oxygen or CPAP. It wasn't necessarily full intubation, but it had to be within the first 24 hours. And so we thought that was the right population to focus on. suitably sick that they may benefit from an anti-inflammatory therapy, but early enough that you could still reverse it. Maybe that is why we're seeing a slightly different result to others.
Any role for biomarker? Of course, IL-6 comes to mind, but it could be CRP, ferritin, lymphocyte count. What do you think? Should we guide our strategies with biomarkers?
So we will look at that in our full analysis, and hopefully the picture will become clearer. My personal thought is that I am not sure in this case whether the systemic biomarkers are necessarily the most helpful, because although many people talk about a cytokine storm, I think we and others have shown that the levels in the circulation are not as high as we would see in other ARDS, and certainly nowhere near as high as we would see in septic shock. I think inflammation is crucial though, and I think it's the inflammation that's happening in the organ beds, the tissue beds, and that's harder to measure with a biomarker. And so I think for this particular case, it may well be the illness severity is the biomarker that tells you there's a lot of organ inflammation, and that is maybe the group to target. But it will be interesting. We've been collecting biomarkers, and hopefully our full analysis will help explain that a bit more.
Mm-hmm. So at the present time, of course, you are involved in clinical trials, and it's of course excellent. But if you were sick, or if your loved one was sick in an ICU, you would insist for some form of immunomodulation to be given. Is it a message?
Well, I can tell you in the UK, we have 142 ICUs taking part in the REMAP-CAP trial, and I would encourage them to randomize. I know by our adaptive design, they will get an immune modulator, and I would feel happy that they were being treated with an immune modulator within the trial, learning which of them is best, but they would also be contributing to the other information. We're testing convalescent plasma, we're testing antiplatelet therapies, and this way we will all learn. And as it goes back to the idea that I think care has improved since March and April because we have the evidence from trials, and so it's important, I think, that we all contribute. So that's what I would hope for.
Sure, but some people who are listening to us may work in a small private hospital in the country out there, and they may not have the possibility to enroll patients in a trial. So they are presently giving dexamethasone in most places. Should they add some immunomodulation therapy, you think? Or you would say, no, wait, we need more information?
I think clinicians should make the evidence on full results that come out in peer-reviewed publications. So that would be my advice. We gave our, I've given as much of the information that our DSMB shared with us where there was signal for benefit, but we haven't seen the whole picture yet. So I think clinicians have to make their assessments at the bedside for each individual patient.
Now, let's say a few words about these platforms, because indeed, Discovery impressed me and impressed many others, and that's how we could really make progress with dexamethasone. But you are more involved with the REMAP-CAP platform. Can you tell us a little bit about the differences between the two?
So the recovery trial is being led out of the UK, and as you say, they produced the dexamethasone result first. They are a large trial recruiting hospitalized patients, any patients who are sick with COVID-19 in the ICU, and testing various therapies that changed over time. REMAP-CAP is slightly different. Again, it's a platform trial. It's international. It's multifactorial. We're testing multiple interventions, but it's one difference is it is in its design. It's a Bayesian design rather than the more traditional frequentist trial, which I'm sure we don't want to go too much in the detail of statistics, but the Bayesian design, I think, is really quite neat for a pandemic. Rather than the traditional way of having to plan a trial with a fixed sample size, expecting an effect size, and then recruiting and performing a statistical test, and then getting this p-value, a magical p-value. The Bayesian design, we predefine triggers for where we will declare things superior or inferior. But what we do is you say, what do I know already? Generate more data, calculate what they call a posterior probability. And using the data you've seen, if that then is convincing enough, the probability is high enough that you've seen a difference, then you say there's a difference. And it means that you can declare a result as soon as it's seen. And you don't have to make guesses in advance. If it's a big effect, you will see it early. If it's a small effect, you will see it late. And you keep on going until you get a definitive answer. And there's none of this stopping and go, oh, maybe there was a trend. If only we'd recruited more. We keep on going until we get an answer. And I think that's what we're seeing so far. We're getting answers very quickly. So I think it's a neat design that's helping the pandemic. And I wonder if this is something we should think about for the future outside of the pandemic, to get better answers to improve our care in general in the ICU and maybe in the wards as well.
Good questions. Now, of course, COVID-19 is still relatively homogeneous, even though it's not totally homogeneous. It's a disease. Whereas when we start with pneumonia or even worse, sepsis or ARDS, it's becoming perhaps a bit more difficult. A word about the other international networks, Solidarity, Discovery. What do you think?
Yeah, I think they have their place. I think international collaboration is the way we should go forward. And it's been made obvious to us in a global pandemic that we need to work together. And I think this is important. And so it's been very impressive seeing thousands of patients randomized into trials all over the world, giving us answers. And I think this is maybe one of the silver linings that comes from this very dark cloud that we're all under at the moment, is that we learn to collaborate more as investigators and improve our care. And it seems that this is only the best way for us all to move. So I'm in favor. It's hard work.
But it's fundamentally important. And we spend too much time on hydroxychloroquine, right? I mean, there were so many trials. When you look at the number of clinical trials in COVID-19, there were so many on hydroxychloroquine. We could have tried many other therapeutic options. So we are reaching the end here. So I'd like to know, what do you find very promising in the treatment, besides immunomodulation, plasma, antibodies, maybe before the ICU, I don't know, ACE2 receptor, what do you think? Or maybe simple things like melatonin, what do you think? What could be particularly promising in your view?
So I think there's two aspects there. Some of those I think are general interventions that may be helpful for general intensive care. But specifically for COVID-19, I think we are testing plasma. We await those results. So hopefully that is helpful. I think the antibodies, monoclonal antibodies against the virus, are clearly very exciting. It would seem, again, following the biology, that it's probably earlier in the disease that you would expect to see that benefit. But I think that would clearly be important. I think not necessarily just the immune modulation, but I think I will come back to it, because we're seeing with the recent genomics study that came out showing clear polymorphisms within the various inflammatory pathways that seem to potentially be causal. That a neat analysis that was done by Kenny Bailey and others in that team, suggesting there could be other drug targets that we should focus on. So I think that is a very exciting way to go. Even though it's in the same field of immune modulation, we can hopefully still learn around it. So I think there's an awful lot of exciting areas. The other one, just thinking, it is the virus interacting with the ACE receptor. And again, people have proposed exciting drugs there, not just ACE inhibitors, but maybe more targeted therapies around the ACE receptor, stopping
ACE2 receptors that you could give. Yeah.
I think that's it. This is clearly the virus is doing more than just affecting the lung in this disease, and so we need to understand that. So I think there's a lot of excitement, exciting treatments that need testing that will be developed over time.
It's amazing. Huh? We have been into that for months, and we are just realizing that there are many other options that we could have tested earlier. Yeah, Chinese herbs.
Things have moved at such fast pace. I think it's difficult. At the beginning, no one knew what to do, and we've learned so much. But again, I think this shows when everybody is focused on a single goal, how much can be done in science. We should be pleased about that and find these ways to learn to take this forward as hopefully the pandemic eases sometime next year.
Yeah, we are living very difficult period, but at the same time, it's very challenging and very exciting. So it's a real pleasure talking to you, but I see that the clock is ticking and we'll have to bring it to an end. So I'd like to thank you very, very much and really applaud your efforts to improve our management of these patients. So many thanks, Tony, and take care and have a good holiday period.
Thank you.
Take care.
Happy Christmas.